Diabetic Pedal Osteomyelitis, Concepts and Controversies, Part 2. My name is Marlena Jbara. I'm an MSK radiologist from Staten Island University Hospital, Northwell Health. In Part 2, we're going to follow up on the pathophysiology with an update on the role of imaging. We're going to look at MRI, nuclear medicine, and future imaging pathways. We're going to sort the statistics. And then finally, we're going to finish with American College of Radiology appropriateness criteria with regards to imaging of the diabetic foot. Moving on to the MRI, I bring back our eraser to remind us of the fact that on the bottom right picture, on this T1 weighted image, you can barely see the outline of the confluent infiltration of the fifth distal phalanx on this sagittal image, which you can clearly see outlined by this light bulb T2 weighted bright signal at the top left image, denoting osteomyelitis and the go sign. The power of FDG PET is that the standard uptake value may even differentiate Charcot from an infected Charcot. This example on the right, you can see the low resolution physiologic image with uptake all around the great toe. The hallux metatarsal. And you can see that we can put color on that, make that prettier. And of course, we can fuse that to a CT image where we can see that this is all periarticular, osseous infection around the bone, but not within the bone. And of course, on this example down on the bottom right, we can see that there was a separate area in the talus had a standard uptake value that was infected. And of course, there's this area down below that's showing the periarticular infection, the periosseous infection. And the positive predictive value for MRI in these cases versus FDG PET, FDG PET is outperforming at 78% positive predictive value to be able to establish whether or not the disease is present, where MRI may be 56% in this nice article out of Molecular Imaging and Biology in 2010 by Nawaz.